Hello, I'm David Tollerfield. I'm a retired podiatric surgeon and I'm also a former patient who had Morton's neuroma and treatment, which included surgery some 9 years ago. I would like to share today my first talk in a series of 3 talks, which you can find on YouTube or my website, davidtollerfieldauthor.com. I'd like to look at some of the realities of this condition and why people are getting so confused. So we need to look at the early stages to start with. This is where hopefully you can diagnose the problem yourself. And we want to start to more or less keep an eye on, a diary if you like, on those symptoms as they progress. And it's only when nothing else works that you should perhaps be seeking some assistance. Now, depends upon how long it's been there. That assistance might be needed to be engaged in earlier. But the whole purpose of this talk is to try to get you to see if you can help yourself so you don't need to seek further help. So there's a little bit of self-diagnosis as well. The early stages are more or less, if not always, associated with footwear. And I can say this because, in fact, that was my own experience where I had a switch to some footwear which was not altogether suitable when I was cycling. These were the clip-on cycle shoes. So for a male, it's more unusual than females to experience this problem. We know that female shoes come in various shapes and sizes. Not everyone experiences it, but if you do, it's the compression that causes the forefoot to pinch on nerves, and that's something one needs to address. So in the early stages, always look at footwear. Now, the nerve that relates to the condition is usually found between these small long bones in the foot called metatarsals. The 3rd to 4th metatarsal, we have 5 metatarsals, concerns a nerve which has a small branch as well coming from another direction. While this isn't always the case, it does find itself nipped off. And if we have a look at this picture here, we've got what is a sheath to a coil of wire. And if you think of the nerve, the neuron, which you can see on the right-hand side, has this myelin sheath. It's pretty similar. And nerve conduction is efficient because it jumps between these little gaps or nodes. And this provides a nice fast conduction. So that's fairly simple, but if we have a neuroma, we get to have interference in the transmission of nerve signals. This is a slightly more complex picture. On the left-hand side, we see the structure in cross-section. We see the 2 main vessels, but it's these small vessels called vasa nervorum, which actually get blocked off due to damage. They get little clots in them. And the other aspect of it, if you see the nervi nervorum, these are small nerves that actually supply the nerve itself. Inside the nerve, we've got bundles, and those bundles are in fact cause both motor and sensory message transmission. Motor relates to muscles, and the sensory side really relates to the skin. And it's the skin that we are probably feeling more than the motor side. But if the nervi nervorum are affected, we're going to get some additional symptoms along the way. On the right hand side, you can see a picture of a nerve coming out, and that's actually a Morton's neuroma coming out, although it's between the 2nd and 3rd interspace in this particular case. 25% of cases are affected between the 2nd and 3rd rather than the 3rd and 4th intermetatarsal space. So let's have a look at a very simplistic diagram. On the left-hand side, this is normal. We see a small blood vessel here. That blood vessel starts to become blocked off. The term is occluded, if you like. It has little clots in it. Just like we see in bigger vessels, this affects the small vessels. And that alters the structure. So we see scar tissue developing over not just months, but actually years. And as the scar tissue develops, you actually start to see changes in the growth of the neuroma. And that's why it is called a neuroma at that size. It's a benign tumour. It's not actually a malignant tumour, even though it's called a neuroma. And as it gets larger, it's more easy to crimp off. and cause the sensations. Now, the sensations come from both the main nerve itself, or the bundles of nerves, as well as the nervi nervorum. So this is why we get different symptoms. As it enlarges, the scar tissue becomes thicker, and it impacts upon the local vessels and the local tissues as well, compounding the problem. So it really comes down to size, and if you know very little about neuroma, it's all a question of how big it becomes. Work has been carried out, research work, proper research work that is, using a number of cases and studied with histology. That's where we send the sample off to the laboratory and have a look at it under a microscope. And it's been suggested that anything from 6 millimeters upwards, it's not specific, but 6 millimeters upwards is more difficult to treat conservatively, that's your self-treatment, than it is if you have some intervention. Once it gets large, the symptoms increase, and those symptoms will vary from pain to sensations of shooting pain, paresthesia, which is a kind of electric shock towards the end of the toe. And that really confuses us because it appears at the end of the toe rather than the location. Now we see these ligaments underneath the nerve itself, and if the nerve grows, it has nowhere to actually move. Nerves, like all tissue in the body, have to move with an elastic ability as we move. Bones move, joints move, nerves will move with them, blood vessels move with them. But once it becomes scarred in, you actually can't see it move. It won't move, and it becomes tethered down, anchored, if you like, to the ligament. And if it becomes anchored to the ligament, just cutting the ligament alone won't in fact necessarily work, because you've still got the elements of the hard tissue there. So you actually see the metatarsals here. You can look at this. It's between the third and fourth metatarsal in this diagram. And you can see, as I say, the ligaments underneath. If we look at these tests, these common tests here, we can see the pinch test here, which is quite sensitive to picking up an early neuroma. However, it does have to be of a reasonable size before you will get those symptoms. So you might get some just general discomfort. I mean, if you squeeze the skin on any part hard enough, you're going to get symptoms. This is a definite change. So if you compare left and right foot, unless you're unfortunate enough to have a neuroma in both feet, try this test. Say, press down between the forefinger and the thumb. And if you feel that it's a little bit firm and uncomfortable on just relatively light pressure, there's a chance that this is localized. Now, I have to tell you that sometimes it's associated with other conditions, so it's not 100%. But in terms of our research that's been carried out, it is pretty specific to Morton's neuroma. We then use the other test where we actually compress the metatarsals together. And what will happen if the neuroma is of a sufficient size, what will actually happen, it will pop up and make a little clicking sound. This is known as Mulder's sign or Mulder's click. And you'll also get a radiating irritation towards the end of the toe. As the nerve and symptoms become more progressive, unfortunately, you're going to get burning pain, and the intensity of the discomfort will be certainly replicated when we start to walk or carry out any activity. It'll feel as though there's a stone in the shoe, for example, once it gets to a significant size. So you see, I keep coming back to size. Size will equal the symptoms, size will equal the prognosis, that is the ability to actually achieve some kind of outcome. So in order to identify what this nerve's about, once it gets to a reasonably significant size, we need to do an ultrasound. Now, ultrasound is a non-invasive technique. We all know what ultrasound is because obviously we've seen it when women go in to have their babies assessed in terms of size and the progress. In much the same way, we can do the same with a neuroma. It doesn't take very long to do, and you get some good images, and you can actually find out what the size is, which I'll deal with a little bit more in the second video later on. The timeline. I'm pretty big on timelines, and the whole point of this little curve here is to show you that frankly we don't really know what the timeline is, because the symptoms to start with are so small and insignificant that at the end of the day you may think it's some other condition until it becomes more persistent. When it becomes more persistent, you don't really want it to get to that arrow where you're past the point of no return. So once you get these electric shocks, these tingling sensations we call paresthesiae, certainly that is the time to take it seriously. Paresthesiae does equate more closely to nerve damage than any other type of pathology or problem. Once we do have it there, we want to try to reverse it ourselves, and that's what we need to concentrate. So footwear, coming back to footwear, that's terribly important. Get the right footwear, make it a little bit wider, reduce the heel height a little bit and see if this improves. Some of the other things you can do include massage. Now, again, if the neuroma is too large, it's going to be pretty uncomfortable, to be honest. It's a question of how much you can tolerate. But the idea of massage is to break up that scar tissue. Remember, the scar tissue that forms around the nerve, the more you can break that up in the early stages, the better it is. So it may be a little uncomfortable, providing that the symptoms wear off and it improves. It's a bit like reflexology in a kind of broad sense. So do use massage with a soft ball. You can use a squash ball, they're nice and small. The softest one, not the hard ones. And that's good. Some people use tennis balls and so forth. The internet, great place. You will find everything on Facebook and other social media platforms. This is where people get together and give advice. Now, I want to point out to you, which this is great. I have absolutely no problems with it. But time and time again, I read someone who's had treatment or has been advised to have treatment. They're trying to pass that advice back to individuals. And the problem with that is that it's not one treatment that fits all, because no one talks about the size of the lesion. If the lesion, that's the neuroma itself, is small, certain things will work better than later on. If they're large, they may very well be amenable to conservative treatment. When I use the word conservative, I mean non-surgery, such as injections. Again, I'll deal with that in more detail in the second talk. Pain scale, well, we all know what we can tolerate. It's based on race, it's based on gender to some extent. So our genetics play a big part in whether we feel something or we don't feel something as badly as someone else. And so as a consequence, we can't always say an equivalent pain that I have will be the same as maybe my wife or my children. But once we start to get to 4 to 5, generally speaking, we consider this to be significant. That's when you do need to seek help. And that's really where we need to go next if self-help doesn't work. Before we go there, let's talk about the options with insoles. Now, insoles are those things that slip into shoes and they've got pads in them some of the time, or they might have a little raise on the inside. See the arrow on the left-hand side with that dome? Well, those domes aren't much use if they are behind the line I've just marked on there. If you see to the right-hand side, the white pad is in the right place. So you need that edge just underneath the metatarsal heads. And the reason you need it there is because it lifts the heads up and separates the metatarsals to take pressure off the neuroma. Again, if it's early symptoms, these can work fantastically, and it's well worth considering these or investing in some insoles with a dome, but the dome needs to be in the right place. You don't always have to get insoles. You can actually get pads with domes in them, and so you can move them around until they're in the right place. Don't forget, they fill up shoes. If they fill up the shoes too much, the pain that you're going to get from neuroma actually gets worse. So there's a downside. You've got to actually make sure you've got space in the shoe, in the toe box. The other type of modality that you can actually buy from chemists and the internet, and you can also buy from some outlets, sports shops as well, are the 3/4 length orthosis, which has a nice deep heel cup with a stabilizing rear post to it. These are all prefabricated. They range from probably quite low prices to very, very high prices. But at the end of the day, you do need something that's a little bit firmer, and it comes behind the metatarsal heads, so it's 3/4 length. It fits into shoes much more readily than some of the insoles will and takes up less room. And it has this raise on the inside, which actually also assists control the foot a little bit more. Now, this is something I've personally used for a long time. I still use it today, even in post-surgery terms, because it helps my foot not irritate the area where the surgery being performed. So this is really well worth purchasing yourself to start with and using it for a number of weeks. So if we look at the timeline overall from A right the way through to E and surgery, we can actually see we can have clear stages. A and B you can do yourself. C is where you need assisted help because the symptoms have started to increase and everything you do isn't helping. I do suggest you don't leave it. Try and seek help from a podiatrist. You'll find your GP will not know as much about neuromas as a podiatrist will, because this is our specialty, or go to an orthopedic foot surgeon who will also give you advice. I think that everyone, and certainly those that make messages or leave messages on social media platforms, say, I have seen my surgeon, he wants to operate. Well, you can always ask if there are alternatives, such as injections and so forth. This is really well worth exploring before surgery. And I do deal with this very extensively in my book, Morton's Neuroma, Podiatrist Turned Patient. This has got the support of the Institute of Podiatrists, an organisation in the UK that trains both foot health practitioners and podiatrists. So in this first little talk, I've dealt with self-help and a little bit about what it is that the neuroma is and why self-help won't work. In my next one, we'll be dealing with clinical treatment and the evidence behind clinical treatment, such as injections, as well as cryoablation, high-frequency ablation, and so forth. And then my last one, it'll just deal with surgery alone, so it doesn't confuse things. So thank you very much for listening. I hope you'll find this as valuable, and please do share it. That would be great.